Thank you so much for joining us today for our Miami Pediatric Neurosurgery Zoomposium. We're excited today to focus on the topic of pediatric epilepsy. I'll turn it over to Dr. Niazi now.
Great, thank you. So tonight we have an excellent panelists and speakers, and so I want to thank both of our speakers for joining this evening. I have the pleasure of introducing Dr. George Ibrahim, who is a good friend and also one of our former fellows. So he is now an assistant professor in the Department of Surgery and the Institute of Biomedical Engineering at the University of Toronto. So thank you so much for joining us this evening. And then just let's remember, if you guys have any questions, to go ahead and use the question and answer tab and submit your questions for us. Off to you, Shelley.
Great. Thank you so much, Dr. Niazi. So we really look forward to hearing Dr. Rukka's talk at 5 p.m., followed by Dr. Ibrahim's talk at 5:30. And then at 6 o'clock, we have a question and answer period with a moderator panel featuring Dr. Caitlin Hoffman, who's a pediatric neurosurgeon at Cornell, in addition to Dr. Glenn Morrison, Professor Emeritus in Miami, Dr. John Ragib, who's the Chief of Pediatric Neurosurgery here at Nicklaus Children's Hospital in Miami, and myself, who is a pediatric neurosurgeon. So it's really such a pleasure for me to be able to introduce our first speaker, Dr. James Rukka, who is a professor at the University of Toronto and neurosurgeon and senior scientist at the Hospital for Sick Children. Dr. Rukka will be speaking about the evolution of pediatric epilepsy surgical techniques and the experience at the Hospital for Sick Children in Toronto. And as many of you may know, Dr. Rukka is really a giant in the field of pediatric neurosurgery and one of my most respected mentors. He joined the Division of Neurosurgery at the University of Toronto in 1990 and has been a surgical staff at Hospital for Sick Children since then. He has an extensive repertoire of clinical and academic roles. Currently, he is director of the Arthur and Sonia Labatt Brain Tumor Research Center, and he is the McLaughlin Chairman of the Department of Surgery at the University of Toronto, in addition to the Editor-in-Chief of Neurosurgery, Editor-in-Chief of Journal of Neurosurgery. And previously, he has acted as the Dan Family Chair in Neurosurgery at the University of Toronto and served as past president of the WNS. Additionally, he's a very talented athlete and musician. He was made an Officer of the Order of Canada in 2015 and the recipient of the WNS Cushing Medal in 2019. So thank you again, Dr. Rukka, for speaking today on the experience of building the epilepsy program at Hospital for Sick Children. And I'm going to turn the podium over to you.
Great. Thanks, Shelley. Hopefully you can all hear me just fine. And it's a great pleasure to take part in this symposium. And I think the University of Miami is doing it really well. I see all these great offerings coming out of the University of Miami. I think I'll also be speaking on the adult side later this coming year. But really, Shelley, thanks to you. It was wonderful to see that you landed at the University of Miami, and we're really thrilled with how well you're doing, having received your training initially at the University of Toronto. I'm really pleased to share this podium today with my colleague, Dr. George Ibrahim, from whom you'll hear later today. It's great to see Toba, great to see my colleague, John Ragib, and Caitlin Hoffman, who has trained here at Sick Kids years ago. Wonderful that Caitlin will join us in a bit. And Heather, lovely to see you. So anyway, thanks, folks, for having us here. I'll talk to you a little bit. What I thought would be kind of interesting for all of you is talking a little bit about my experience over 3 decades now. It's hard to believe, but yeah, I've been working away at epilepsy probably for 30 years or so. So I thought it'd be really good to actually talk over what's changed, what's kind of new, you know, what's coming down the pike, and what do we learn from the days when we were doing stuff that we're not doing anymore. So with that introduction, nothing to disclose for this presentation from my perspective, but I do want to acknowledge one of the giants of early days pediatric neurosurgery, Dr. Harold Hoffman. And below that, you see one of his papers on an open resection for hypothalamic hamartoma. So we've kind of moved away from doing those nowadays, and I'll talk about how we're doing them today. But I learned a lot from Dr. Hoffman when I was a junior staff, and he was one of the most influential pediatric neurosurgeons in his day. I think John Ragib would agree with that. He was very opinionated, but you know, he had a lot to say. So it was good for me to learn from Dr. Hoffman, and I did learn epilepsy from him years ago, epilepsy surgery, that is. We have a big team here at the University of Toronto. I just want to acknowledge my colleagues in neurology. I know it's the same in Miami and elsewhere for those who are on the line. attending from outside. But neurosurgery, my colleagues here, including Dr. Ibrahim, neuroradiologist, I'll be speaking about Dr. Wajaja in a moment. But neuropsychology, monitoring, navigate, we have it, and this is what you kind of need to do epilepsy nowadays. These are some of the technologies that have evolved, and none of these was available 30 years ago, none. So this is what we've kind of come to learn how to use nowadays. I'll be speaking about all these acronyms throughout the presentation, but if you look at the screen, you can see that we've gone from not doing any of these technologies or using them to using them all stepwise. And we probably have the world's largest experience with magnetoencephalography in children, and it has the best spatial and temporal resolution of all the modalities that we use to image the brain and to find out about epilepsy. In the years that we started using it, we were able to define what a cluster is and what's important about certain patterns on MEG versus what's not important, like if you don't have spike sources. I don't know, Shelley, if you've got MEG at the University of Miami, but we use it characteristically and frequently, and we've been using it for years. The trouble with MEG is that it's typically not ictal, right? It gives you interictal data, but here's an example of an ictal MEG on Rasmussen's encephalitis, and you can see the central or Rolandic area is lighting up with MEG spike cluster. So, and this would be a case where obviously you would do a hemispherectomy. But we've learned how to use the data from MEG to help us with resection. So here's a spike cluster in a child who had encephalomalacia from an old head injury, but this was the area that was leading to epileptogenesis. So we just did MEG guided spike cluster. We actually didn't do much in the way of invasive monitoring for this case or doing pre-resection workup. And this worked really well in this child's case, seizure-free off medication. So yeah, we've been able to use MEG to our advantage for select cases. The other thing that's come to play in the last 30 years, of course, is mapping Eloquent Cortex. And some of this was available 30 years ago, but actually not much of it. So these are some of our publications, including recently Pediatric awake craniotomy and how often we're using this. I'd be interested to hear what the panelists say about how often you use awake craniotomy in children, but it is one of the tools that we have in our armamentarium that we can use in select cases. But we use this very frequently. So direct motor cortex mapping using the monopolar train of 5 technique. And we find this has advantages over the Penfield technique in terms of not causing seizures during surgery. And we can use it throughout the case, which is something, continuously, which is something you may not be able to do with the Penfield technique. The other technique that's become more widely available is subcortical stimulation. Here's a child with, you can see here, sort of peri-Rolandic hemimegalencephaly. And when you compare it to the other side, you can see the distinct lesion here. So by removing this cortex at surgery, we were trying to stay safe and using subcortical stim all the while to prevent getting into the cortical spinal tract, which you can see here in yellow. So this was a very useful strategy for us in the management of polymicrogyria. So this technique also wasn't available, high frequency oscillation observations. And what are they? So, the normal rhythm of the brain is about 30 hertz. But when you have a ripple range that's at least 3 times that, up to 150 hertz or even faster, 200 hertz, you get these high frequency oscillations in the brain. And it's thought that they represent potentially localizing to the epilepsy onset zone. So for many years, we were using this technique to help us, especially when we were using subdural grid monitoring, to identify regions of epileptogenesis that were compatible with resection. Here's a video. Hopefully you can see this, but here you can see on the left-hand side, the EEG will turn to a high frequency oscillation. And there you can see it on the map in this cartoon form, where you can tell where the seizures are coming from and how we had to approach that zone in order to get seizure freedom. Over the years, we've published a number of papers on this topic of high frequency oscillations from sick kids' experience. And it's been, it's been a useful tool. But again, 30 years ago, it didn't exist. There are some limitations to high frequency oscillations, and I'm listing a variety of these here for you. We don't have long-term follow-up data for these, but this is the current, model that we use for looking at HFOs and where they fit into the overall picture when it comes to isolating and determining where the zone of epileptogenesis is in children. Lots of imaging has come into play. So diffusion tensor imaging. This is an example of a child who had a hemispherectomy and was seizure-free for like 7 years, but then came back with seizures. And we used DTI to determine that there was one small band of continued connectivity that needed to be separated. And when we did that, the child did much better. So using DTI to help us, DTI wasn't available 30 years ago. Now we can use it for a variety of cases when we want to know where the important, cortical spinal tracts are, Rolandic region. Pink on these slides are lesions that we approached, and of course yellow are cortical spinal tract and eloquent brain regions that we wish to stay away from. So again, DTI was something that was not in existence a few decades ago. Especially useful to use DTI when linked to navigation and neuromonitoring when we have lesions in the brain that are either abutting, eloquent cortex, or sometimes even embedded within regions that we want to remove. Okay, another thing that we've become familiar with identifying is bottom of sulcus dysplasia. And this is a form of focal cortical dysplasia type 2. All of us have looked at hundreds, if not thousands, of MRI scans, but sometimes these lesions will evade our detection, and we sometimes need a specialized radiologist who reads epilepsy MRI scans in children to be able to find them. And I'll show you some examples. And this is Dr. Wajaja I mentioned at the beginning of my presentation, and she's the one who helps us identify some of these very small and subtle lesions, which now we go to and resect without necessarily needing to do a lot of invasive monitoring. And I think George had a case this week or last week that he just did, where it was a navigation-based resection of presumed bottom of sulcus dysplasia. How about this one? This is an area that Dr. Wajaja saw embedded within the DTI area that was considered cortical spinal tract. What do you do about that? How would you approach that one? So we did, and we were able to resect it minimally invasively, following a sulcus from the somatosensory cortex down. And the child did extraordinarily well and has been seizure-free. So that's been another advance that we've had over the last several decades. I want to acknowledge Carter Sneed, because in about 1995, he came to sick kids from the University of Southern California, and he brought the subdural grid monitoring technique with him some 25 years ago. And we used that to help us for a number of years, a couple of decades, to identify children who would be the beneficiaries of epilepsy surgery. And what I'm showing you here is a paper that I'm quite proud of. It came out in, I think it says, 1999, but in any event, digital cameras were just, brought into play in 1996 or 7 or something. And then a couple of years later, we showed that you can use the digital cameras to use PowerPoint presentations on top of to outline for the benefit of the treating team, but also for the parents, so they could see, what we were planning to do at the time of surgery. And this was actually a huge benefit for those cases. But invasive subdural grid monitor, it's called invasive for a good reason. I mean, we're doing a big craniotomy. Here's a case of subdural grid, but also depth electrodes. So there are some complications associated with it, but by and large, most groups, I know, including yours, in Miami, were able to use this technique to full fruition and get good results. But we've since, migrated from a primarily based subdural grid monitoring procedure now to stereo encephalography, or SEEG. And this is kind of the setup that we have now at sick kids. We're still using the Lexcel frame, whereas I know many centers are using the robot. We have purchased a robot, and we hope to get it soon, but it hasn't arrived yet. But we look forward to using the robot for our stereo EEG cases in the near future. And then laser ablation. I know you've got that at Miami, but we're now using the laser to help treat in a minimally invasive fashion a number of conditions like callosotomies, SEGAs, periventricular heterotopias, FCDs, and hypothalamic hamartomas. The system that we have is the Monteris, where I think your system is the Visualase. But there are a number of publications now that have come out on the rationale for using the laser for a variety of different conditions. But probably one of the big ones is the hypothalamic hamartoma, as you all know. To get started with laser, for those that are not at the University of Miami, might be attending from elsewhere, 2 systems, as mentioned. Navigation's kind of nice, workstation, the Stealth, and a team of professionals. And then finally, you need a bunch of money because these cases are fairly expensive, and we needed to have a fully separated but integrated intraoperative MR unit, which is what we're using, as you can see here, as we're doing these cases. Lexel frame, very accurate. It's great, but it is a bit of a rigmarole to set up. Draping is important, access to the MRI scanner, and as mentioned, the planning station. Okay, I'm just going to wrap up by talking about a few so-called regional epilepsy surgery type cases and clinical series, because this takes you back, you know, into the old era before Dr. Ibrahim joined us and before some of you who are panelists were doing your epilepsy surgery, and talk a little bit at first about frontal lobe epilepsy and how this is a very challenging form of epilepsy. And this was our series from a while ago, about a decade ago. And the outcome is as shown here, about 60% of kids will be angle 1. For those that have not seen, let's say if you're online, you have not seen a frontal lobe seizure before, I just thought I would show this as a form of frontal lobe epilepsy. And maybe you can hear the sound as well, but it's not so important. It's just seeing the video and seeing the sort of hyperkinetic movement that results from having a frontal lobe seizure. This is very, very typical. But localizing frontal lobe epilepsy can be the real challenge in so many cases. These are some examples of cases from this series and other cases that we've had, showing frontal cortical dysplasia, bottom of sulcus dysplasia. Look for a cleft, that you can see here. Again, just compare both sides of the brain, and where you see poor gray-white delineation, that's where you'll see the cortical dysplasia. Here's a DNET in the frontal lobe adjacent to the cortical spinal tract, and a gangliogram. So you can have tumors, dysplasias, other lesions that can occur in frontal lobe epilepsy. Okay, let's move for a second to temporal lobe epilepsy. And obviously, this is one of the most important forms of surgical epilepsy in the adult world. It's also very important in children. Counts for about 20% of our operated cases. In fact, I did a case today. And here the outcome should be better than frontal lobe epilepsy. You're looking at between 70 and 80%, if not higher. And these are the most common pathologies. So mesial temporal sclerosis, cortical dysplasia, tumors, and sometimes you can have dual pathology where cortical dysplasia is kind of intermixed with tumorous conditions. So here's an example of mesial temporal sclerosis. This condition is somewhat rare in children. That said, I did a case today of mesial temporal sclerosis, and you can do a resection that looks like this for mesial temporal sclerosis, or you can do a lesionectomy in the temporal lobe, as in this case of a ganglioglioma, and get excellent results based on these pathologies. Here's an example of an approach to a tumor. I think you'd all agree that this is an interesting tumor. How do you get there? What's a good way of going there? We decided to do a transsylvian approach. Here's a video showing opening the sylvian fissure quite widely and then just resecting the lesion that's there. Here's the postoperative image and showing a nice resection, and the fact that by splitting the sylvian fissure, it almost looks like you haven't even been there, right? You've done the approach and it's gone quite nicely, and the patient did extremely well. If you follow your patients with temporal lobe epilepsy long enough, and by that I mean 5 years plus, you'll see a decrement in the outcomes. And so you can see how the Engel scores will go down over time. So while we all talk about Engel at 2 years, which is really important, for temporal lobe epilepsy, and I think John on the line can attest to this, that you follow your patients long enough, you're going to have long-term failures. And those patients can be explored and worked up using some of the techniques I've already talked about, like SEEG or subdural grid monitoring subsequently, and can be rescued at times from having failed their primary operation for temporal lobe epilepsy. So good outcomes. Those with tumors even do better. Cortical dysplasia sometimes has a less good outcome. Talked about relapses if you follow your patients long enough. I think pretty much all neurosurgeons could do this if you have EEG and a lesion that's in the temporal lobe. And I didn't talk much about it, and I won't have time to, about neuropsychology and why that's important in determining and deciding when it is you'll take out the mesial structures. Now, here's a really important paper because one of my co-speakers today, Dr. Ibrahim, is the chief author on this paper. And I think George did this when he was either resident or in the lab in the University of Toronto training program. But occipital lobe epilepsy is interesting as well. It's not that common. It's about 10% of our cases. Localization can be a bit of a challenge. And so we use all the tools I talked about in terms of imaging techniques to try to find areas that might be indicative of children that would have occipital lobe epilepsy. But dysplasia, Sturge-Weber, tuberous sclerosis, and so on, maybe you can get up to 70% Engel class outcomes. That's what we found in our particular series. What's interesting is that while there were many cases that were confined to the occipital lobe, like this case of occipital lobe epilepsy, where this is a cortical dysplasia, you can often have multi-lobar involvement that includes the occipital lobe. So you have occipital plus parietal, occipital plus temporal, and sometimes you have to do quite widespread multi-lobar resections. Although I must say I haven't had to do many of those. Actually, I did one maybe a couple of weeks ago, but they're not so common as they were, as I recall, earlier on in my experience. Okay, I want to talk a little bit about Rolandic epilepsy. And Luigi Rolando, just to remind you, was an Italian anatomist who discussed this region of the brain, the central region of the brain. In his lifetime, he couldn't determine what exactly the Rolandic region did, but he was the first to describe its presence, and hence the Rolandic region is named after him. Early on, like 20 years ago, we discussed this malignant Rolandic Sylvian epilepsy syndrome. And we did some interesting surgery. I just wanted to show this paper here from the old days of multiple subpial transections. And here's a video showing multiple subpial transections. It's mostly of historical interest. Now, that said, I did a case with MSTs probably in the last month anyway. But almost never now we're using this. But this is the technique that we would use to try to preserve function in the Rolandic region, but at the same time, get rid of any epileptic disturbances. The good thing is it did work, but it only worked transiently, and there were quite consistently failures that occurred anywhere from 2 months to a couple of years after we did MSTs. But here's an example of surgical epilepsy for Rolandic seizures. You can see the MEG spike cluster here. This is our mapping. We did subdural grid monitoring. Here's the nice area of epileptogenesis that we found. We're showing you the motor strip here in letter D. And this is the resection that we did. This child has been seizure-free for many years. We reported our series on intractable Rolandic epilepsy. And in this particular series, you can see Engel class scores were not so good as with temporal lobe epilepsy, but the majority of patients had 90% plus decrease in seizure frequency. So we could impact on their quality of lives, but there was also the aspect of functional impairment that has to be discussed. If you're doing big resections like this through the Rolandic region, obviously upfront you have to have major discussions with the families about the implications of that in terms of motor, somatosensory function down the road. And then finally, one of the last things is insular epilepsy surgery. We're doing this now. We've typically done this early on after subdural grid monitoring, and we would do this type of a resection that you can see here, skeletonizing the Sylvian vessels and all that that entails. The trouble with this technique is that you almost always get remote infarcts somewhere. Like they could be small, but it's a pretty tricky area to operate on and not see sort of downstream side effects. So nowadays, we're actually using the laser for a lot of these insular targets. But I thought I would show you that, you know, we certainly started out by doing open resections of the insula. And I know some groups are doing that to this day. Just the last couple of things, Corpus Callosotomy. This was a sketch drawn by Ian Sook. He's a pretty famous medical illustrator, showing here how the corpus callosum is segmented. I do have a video just to show quickly this technique. And this is an interesting case because not only was it a child with drop attacks or atonic seizures, and this is a tried and true method of dealing with that type of seizure disorder, but this child also had tuberous sclerosis, and you'll see at the end of the video the exposure to take out the sega that was there that was obstructing the CSF pathways as well. The splenium is actually the hardest part to do, and exposing the sega that you can see here. So the patient got the corpus callosotomy total, but also removal of the sega. You can do anterior 2/3 or complete callosotomies, as these imaging studies are showing. And you get better results if you do a complete callosotomy, bottom line. Just a nuance for those surgeons that are watching this. I mean, if you look at this corpus callosum, it's really curved down, right? So imagine coming from the coronal suture and getting here. That's a long reach, right? So you have to kind of know the lay of the land for the corpus callosum. Next time you look at a sagittal MRI scan, ask yourself, is the corpus callosum kind of flat or is it curved down like this? Because that has implications on how difficult getting to the splenium is going to be in your studies. And the last thing is hemispherectomy. And I know you do all types of hemispherectomies in Miami, but here's Sturge-Weber, here's hemimegalencephaly, Rasmussen's. Years ago, I learned the technique of the peri-insular hemispherotomy from Jean-Guy Villemure, who described it in the first place in Montreal at McGill. George and I have in mind to do a parasagittal hemispherectomy at some point in the near future. So be interested to hear what others are doing nowadays in terms of technique for hemispherectomy. And you should know that in the 30 years that I've been doing epilepsy surgery, the first reports have come out. In fact, in this month's Journal of Neurosurgery Pediatrics, I think it's online now, laser assisted, I think it was, or maybe it was minimally invasive or endoscopic assisted hemispherotomy. Okay, here we go. So this is the different techniques going from anatomic hemispherectomy, which is a big operation, now down to sort of central vertical, and even now laser or endoscopic assisted. So many different ways now to do surgery that we have available. It's been fantastic to see the evolution of surgical techniques. I showed the imaging that we've been using to help us in our approaches. Navigation, of course, is really important. SEEG has come into the fray now that we're using it more and more often. Robotic electrode placement, I touched on. Laser ablation. We don't have responsive neurostimulation, but we're hoping to get it. You probably have it down in Miami. We're now looking more towards these minimally invasive approaches, as talked about. But what's going to be important, even though you're doing things smaller, you have to show that the outcomes are as good as what we've done, over the past 30 years. So with that, Shelley, I'll conclude and be happy in the question and answer period to answer questions that may be posed by the panelists or also by those attending. Thanks very much.
Great. Thank you so much for a great talk, Dr. Rucka. That was really great. That was, obviously a lot of work and a lot of evolution, significant evolution in the techniques of the Hospital for Sick Children experience in just 30 minutes. So that was very insightful. Thank you.
I think we'll plan to go on to the second talk, and then we'll do questions together afterwards, either for each of you individually or both of you combined. But people, please join in and ask questions on the Q&A function so we can submit them after we hear from Dr. Ibrahim.
Can you hear me okay? Okay, wonderful. And can you see my slides okay? Okay, fantastic. So it is never an enviable task to share a platform with Dr. Rutka, but you know, what a tremendous experience, and I'll pick up on that a little bit and talk about a niche area of pediatric epilepsy, which I think is actually expanding quite dramatically, which is neuromodulation. And before I begin, Heather, Toba, and Shelley, thank you so much for putting together these programs, you know, during the COVID pandemic, and of course for inviting me to speak today. The real emphasis that I'm going to talk about is intelligent neuromodulation, with respect to the various tools that we have to offer, and I'll talk a little bit about what I mean by that as this talk proceeds. I do have some relevant disclosures. I do receive funding from LivaNova and some speaking fees from LivaNova, and some public funding from the CIHR that's related to this talk. It's really particularly meaningful to me to speak at the Miami Zoomposium, given my strong connections to Miami, and suffice to say I have very many fond memories of the time that I spent there, and I often think of my many friends in Miami, especially the late Sanjeev Bhatia, who is shown here in the many pictures showing the times that we've shared together. I am a pediatric neurosurgeon at SickKids with a lab that's focused primarily on neuroengineering and machine learning in neuromodulation technologies pertaining to epilepsy and other disorders in children. I thought I might start with a historical perspective as well, to talk a little bit about what it means for epilepsy to be a network disorder and why that is so important for the treatments that we offer. And this whole idea of an epilepsy network really started in the 1950s, also in Montreal with the work of Penfield and Jasper, who suggested that the ictal onset zone, shown here in the gray circle there, is what initiates the seizures. And the seizures propagate throughout a larger scale network, shown here as little neurons. And identification of this gray area, this seizure onset zone, would then be expected to result in seizure freedom if one were to resect it. And then Talarak and Banco later on went on to expand the idea of the epileptogenic zone. And this includes the ictal onset zone, as well as brain regions that are responsible for early propagation of seizures. And resection of this epileptogenic zone is what they purported to be necessary for prevention of seizures. And other authors, notably Susan Spencer and others, proposed a larger network model of epilepsy, where epileptogenicity is distributed throughout a larger network. And this model proposes that disruptions of connectivity along any one of these nodes that are interconnected would then result in either the prevention or modification of the manifestation of seizures. So from these models of epilepsy as a network disorder, the current treatments for epilepsy can then be inferred. One can resect the epileptogenic zone, you can disconnect the epileptogenic zone from a symptomatogenic zone, or you can modulate the circuitry with electrical stimulation. And really in our contemporary understanding, that means either vagus nerve stimulation, deep brain stimulation, or responsive neurostimulation, which, as Dr. Rutka alluded to, we don't have very much experience with, not at all here in Toronto, due to inaccess to the technology. And of course, we know that neuromodulation has an important role to play in children who may not be candidates for other interventions like resective surgeries. The challenge, though, is that children with epilepsy are very heterogeneous, with a lot of treatment options that are available to them. And these include VNS, RNS, DBS. Now there's adaptive closed-loop DBS. So it's really impossible to know which therapy is suited for which individual child. And I would say that if we were to do a randomized control study of all of these devices, we would probably find that they all have roughly the same efficacy. And it's not because they're interchangeable. It's because we really have no idea how to select the right neuromodulation therapy for the right child, or for the right adult for that matter. And this leads to the danger of the adage that we often quote to patients and families, which is that you can expect about a 50% response rate in 50% of patients. it's actually a completely inaccurate assessment and fails to inform the clinical decision-making that we try to make for individual patients. If we can select candidates more intelligently preoperatively, we may be able to offer them more personalized treatment options, improve outcomes, and promote better resource allocations. And this is what I'm going to focus my talk on, this idea of intelligent neuromodulation for epilepsy. This is our team at Sick Kids who implants the vagus nerve stimulators. There's Dr. Rutka, Dr. Go, and in the background is Dr. Ola. And our team has quite an extensive experience with vagus nerve stimulations, stimulator implantations. But even in the most experienced hands, the response rates for VNS are quite variable in the literature. They range from 26 to 65%. Of response. And although it's a very safe procedure, it's not without risks. And complications can vary from malfunction to hematomas and in rare circumstances, vocal cord palsies. And really these two data points alone suggest that there are a very large number of children who undergo VNS implantations, accept some surgical risk, and don't actually achieve a real benefit. And in the context of at least the Canadian healthcare system, this does lead to inefficient resource allocation and potentially delays to access to therapy for children who would benefit from it. When we look at the clinical literature, there's really no variable that stands out that can predict individual patient responses to treatment. On the left here is a meta-analysis by Dario Englot, mostly in adults, that shows response rates over time, which do improve with VNS. But there isn't really one particular variable that stands out that tells you that one patient will respond and one patient will not to vagus nerve stimulation. This is the largest study in children published in 2011. And again, many children have very good responses to VNS, but it's impossible to determine who will and who won't respond on an individual patient level using clinical predictive variables. Some of our work at Sick Kids, this is Kareem Mathani in my lab, who looked at clinical variables separating responders and non-responders. And as you could see, the responders in the blue circle overlap completely with the non-responders in the red circle, showing an inability of clinical variables to dissociate who will and who won't respond. When you plot this on an ROC curve, you get this finding. And if you're not familiar with ROC curves, the greater the area under the curve, the better a test is at doing what it's meant to do. And as you could see, the area under the curve for clinical variables are essentially along the diagonal, suggesting that they're no better than the flip of a coin at predicting who will and who won't respond to VNS. And then this led us to ask, if these variables aren't helpful, what data can we then leverage to better understand who will and who won't respond to VNS? So earlier this year, these two individuals in my lab, Olivia and Adriana, published a very nice scoping review of all the biomarkers that have been reported to identify individuals who will and who won't respond to VNS. And they grouped them into these distinct categories. They grouped them into systemic biomarkers, structural findings on neuroimaging, electrophysiological activity, and network-based biomarkers. Many of these really haven't been validated aside from heart rate variability in ECG when it comes to systemic biomarkers. This structural findings on neuroimaging, there's conflicting data as to whether this is a positive predictor or a negative predictor with VNS. This is the largest category, which is electrophysiological markers to VNS. And again, ranged quite a lot, multiple different biomarkers that have been studied. Very few of these have been validated either internally or externally. And the last category, network-based biomarkers, is what I'll touch on a little bit more over the rest of the talk. I only mention this to say that these biomarkers take advantage of many new technologies that we heard about in the last talk, including MEG, DTI, fMRI, and PET scans. In this same publications, we summarized the biomarkers that were actually validated by the authors. And this whittled down this large list of biomarkers into much fewer candidates. And validation is a really important method in investigating biomarkers, in trying to determine whether something is effective or isn't. And I'll touch on this in the next few slides. In these validated measures, the sensitivity and the specificity ranged from about 70 to 90%. And the accuracy for these measures was much higher than the clinical covariates, hovering around the 80% mark. Several of these articles were ones that we published using methods that I'll talk about in a second, where we tried to link the effect of several of these biomarkers to the underlying neurophysiology of the mechanism of action of VNS. And I wanted to take this opportunity to discuss some of the foundational studies of the mechanism of action of VNS that's really informed our understanding of the afferent vagus nerve circuitry. Because as early as the 1980s, with horseradish peroxidase studies, it was known that the nucleus tractus solitarius projected to the parabrachial nucleus and to the bilateral thalami. And this is still thought to be one of the fundamental mechanisms of action of vagus nerve stimulation in children and in adults with respect to its anti-epileptic effect. In the 1990s, electrophysiological studies in animal models showed that you can elicit thalamic firing when you stimulate the vagus nerve. And in the early 2000s, during the age of functional neuroimaging, block design experiments showed that different brain regions are preferentially activated in the on state of VNS compared to the off state. And these include regions such as the thalamus and the insular cortex. And metabolic studies with PET scans also implicated the brainstem, the cingulate cortex, and the insular cortices in the long-term effect of VNS. This is studies before and after VNS, after many months or years. But one can potentially predict that if these brain regions are activating at the same time, then maybe they're also wired together in some way, and perhaps that has a way of predicting responsiveness to VNS. And this leads us to the idea of using brain connectomics to understand neuromodulation technologies and specifically responsiveness to VNS in children. The first study of functional connectivity is actually summarized in this fMRI experiment, where Biswal and colleagues had a patient doing a motor task in an fMRI scanner. And on the left here, you see a statistical parametric map of this patient activating the motor network by performing a motor task. And on the right, you see this patient doing absolutely nothing. On the right is a scan that looks at temporal correlations in the functional connectivity in fMRI scan when the patient is at rest. And this study informed our understanding that brain regions that tend to co-activate are also intrinsically functionally connected to each other. And essentially all studies of connectomics involve decomposing communication between multiple brain regions into mathematical structures that you can then study, understand brain networks through, and then relate to outcomes. So on the top slide, you could see that you could take either structural or functional connectivity measures. You could build topographic representations of those measures, and then these representations can be linked to some outcome of interest, including prognosis of response to therapy, and this could be done in many different ways. The underlying hypothesis behind this is that some brains are wired to respond better to VNS than others. And the same could be said for any neuromodulation technology, as I'll talk about in subsequent slides. We tested this hypothesis in a few ways, and this is data actually from Miami, where the earliest of these studies were performed, and we actually found that this is true. We looked initially at thalamocortical interactions in the resting brain and how these differed between individuals who responded to VNS and those that didn't. And we found that there was increased connectivity of the thalamus to very specific brain regions in individuals that tended to respond to VNS and individuals that didn't. And this is all based on pre-surgical imaging data before the VNS was actually implanted. So thalamocortical interactions that we found to be predictive to response included those to the cingulate cortex and the insular cortex. And interestingly, those were the exact same brain regions that were activated by the VNS in the fMRI magnet in those earlier studies that I talked about before. Once we established these findings, we then pooled together data from multiple collaborating institutions, and we found that we can actually predict who will and who won't benefit from VNS in these multi-institutional databases. And I show over here a 2x2 table of the classification of prediction and the actual response to VNS and the schematic of how this measure of connectivity can tease apart those who respond in blue and those who don't respond in red. I won't emphasize this to a large extent, but we went on to show that the same brain regions were also preferentially structurally connected through more robust white matter tracks in responders compared to non-responders. And using MEG, we found that very similar connectivity patterns in MEG tended to differentiate those that responded and those that didn't respond to VNS. And taken together several years ago, we described a vagus afferent network, which we defined as the set of brain regions that are functionally connected and linked to the activity of VNS and relate to the responsiveness to therapy. And we felt that conceptualizing responsiveness to VNS as a connectomics issue allowed us to then theoretically model intrinsic brain differences within this heterogeneous population of patients undergoing the same therapy and associate them with outcome. Maybe the most important slide, though, is this one, where you'll recall I showed that the ROC curves for clinical variables were no better than the flip of a coin at predicting who will and who won't respond to VNS therapy. I show here the ROC curves for the various different modalities investigating connectomic profiles, which are significantly better. And as our models become more refined, we're also aiming to test more advanced machine learning models using data that has undergone fewer and fewer pre-processing steps that's potentially more applicable to many more centers. There are some very important questions that remain, including the threshold for response, what this means for quality of life, the effect of programming, early versus late responders, the effects of more complex models. And these are questions that we hope to answer through a prospective study that includes, of course, Shelley in Miami and many others who I'm grateful to collaborate with, where we're looking at how connectomics can predict outcomes after vagus nerve stimulation. And these are data that we're collecting in a prospective manner to try to tease apart how we can better identify which child will benefit from VNS and which child won't. And I started this talk by talking about the danger of the 50% response rate and 50% of the population, which really isn't meaningful. And we need to develop more and more advanced tools to try and identify who will and who won't respond to neuromodulation therapy. This is particularly important because we have more tools at our disposal than just VNS. Since 2018, for instance, we have had a regular biweekly DBS clinic at Sick Kids, and this is our DBS team. And we've started a fairly robust program aimed at pediatric DBS for epilepsy and other conditions. This was our first patient who was treated. You could see it made the news here in Canada. This is Andy 3 years ago, who was treated because she was having over 150 seizures a day. And she had a VNS that was implanted and she did not respond to it. Our DBS program has since expanded quite rapidly into movement disorders. We have several clinical trials ongoing for novel indications, and this is really a tool that we have to offer that's been underutilized in children. When we talk about DBS, there's really a lot of mechanisms of action that have been studied. And this slide is really to impress rather than to inform, only to highlight that there are significant knowledge gaps in how DBS works. And it's actually very likely that the different indications for DBS that are characterized by variable latencies in the clinical response that you see are also associated with different mechanisms of action. There's several targets for DBS that have been utilized in children. Largely, the two are the centromedian nucleus and the anterior nucleus of the thalamus. We've implanted both in children through our DBS clinic. And it's actually very timely because just this month, I think a few days ago, the 10-year follow-up of the Santé trial was just published in Epilepsy, showing a reduction of about 70% in the most severe debilitating seizure type in the long run in patients, these are all adults of course, that have undergone DBS in the Santé trial. We looked at DBS in children and what the evidence for it was, because this is admittedly a very unique population. What's really interesting is that although the anterior nucleus is the preferential target for adults, I would say, in children, that's not the case. It's actually the centromedian nucleus. And I think that this likely reflects the fact that most children present with extratemporal epilepsies, which are less amenable to neuromodulation with anterior nucleus stimulation. Certainly in our experience, we've implanted about half a dozen or so children, of which all of them were centromedian targets, except for one that we've implanted with anterior nucleus. Overall, when we look at the literature on DBS in children, 85% of them presented or resulted in reduction in seizures, which coincides with our early experience through our DBS clinic at Sick Kids as well. It's really important that the complication rates to realize that the complication rates in children are different than the complication rates in adults. And there's also a lot of complications that we may not even know about in children yet. This is one of our children that we treated with centromedian nucleus DBS, where with one of the programs, with one of the electrodes and the volume of tissue activations, we found that the child developed quite severe aggressiveness that was completely reversible with alterations of the DBS programming. We actually mapped the networks that resulted in the aggressiveness and defined a completely novel pathway between the centromedian nucleus and the prefrontal cortex that was previously unrecognized or previously had not been described. There's also a wealth of technology at our disposal to better perform DBS in children, including systems that record in addition to stimulate. And this is the device that we use, and I have to say I have no stake in this. I have no association with Medtronic, but this is the Medtronic Percept device. And I'm showing here the power spectrum in the anterior nucleus during seizures. You could see that you can list seizures as event markers and define the power spectra in seizures. And this could be used to optimize programming and to better understand epilepsy syndromes in children. Given what's unknown about DBS in children, we have approached all DBS in children as investigational, and we've proposed an ethical framework in how this could be done. And the main aspects of this framework really pertain to approaching DBS within a developmental context, some caveats around informed consent, being cautious about applying adult data to children, and some recommendations about reporting DBS in children. We also have a robust prospective multi-site database that captures nuances in the effect of DBS in children. We also have collaborations with other registries, including the PDDBS registry, to complement each other's efforts to really capture these nuanced data and to understand how this novel neuromodulation technology benefits children and how it could expand within this population. I'll close by saying that the last decade or the last several decades have really changed our understanding of epilepsy as a network disorder. And undoubtedly, the future of pediatric epilepsy surgery will encompass, to a large extent, neuromodulation technologies. Central to these efforts are to really better understand the neural network basis of epilepsy in children and how these treatments can be implemented to remediate them, but also to try and identify how brain network differences in this heterogeneous population leads us to understand how different treatment options are more suited for one child versus another. And with that, I'll stop and acknowledge the amazing students in my lab in medical sciences and engineering who are really, I think, pushing the boundaries to deliver these forms of intelligent neuromodulation to children, and stop there to take any questions.
Wonderful talk. Thank you so much to both of you for your talks. While our moderators start the discussion and some of their own questions, I'll encourage the audience once again to add in some questions. I see we have a couple so far, which we'll make sure we ask the panelists, but hopefully more of you will send in your questions.
Those were a couple of really great talks, Dr. Raka, Dr. Ibrahim, and obviously SickKids is really at the cutting edge of research in epilepsy and many other aspects of pediatric neurosurgery as well. So we're very fortunate to be able to hear from both Dr. Ibrahim and Dr. Raka. So while we have questions coming in through our chat box, and we encourage you to just type your questions there, so maybe I can start off by asking Dr. Ibrahim a couple of questions. You presented a very interesting research on neuromodulation and connectomics, and of course, it's always a pleasure for Miami to be able to collaborate with SickKids. At this time, with the data that you have, and I know that this is an ongoing research project, can you just walk us through your thought process and some of the clinical and radiographic information variables you consider when you assess a patient for their eligibility or for their candidacy for VNS? What kind of things do you look out for, and how do you use that information to counsel families?
So yeah, great question, Shelley. So I have to say everything that I presented, I think is really going to be prime time in the future, but it's not quite prime time yet for a lot of these tools. I don't think we should use these connectomic profiles until they're validated in prospective studies, which are ongoing and which we're pursuing. One of the things about VNS is often we pursue it when we reach a point where we have nothing else to offer families. You know, sometimes we say infantile spasms, the seizures are too short, the VNS won't activate in time, there's not enough time to modulate the neural circuitry, maybe those aren't the right seizure type. But as I mentioned, there really is no one variable that can be used to guide decision-making around who is best to implant and who is not, which is why we need more intelligent tools at our disposal to help tease apart the responders and the non-responders. I think in our experience, and certainly Dr. Rutka and the panelists, I'd be very interested to hear your thoughts on this, but in many ways, VNS is used as a tool of desperation and last resort, which I think is a missed opportunity, because there is a population that stands to benefit more through these neuromodulation tools like VNS or DBS. We just haven't identified who they are yet.
Wonderful. So which biomarkers are you using now currently in your clinical practice?
Of the ones that I've discussed, none.
Yeah. Okay.
None are being used. And to my knowledge, I don't think anyone around the world is using them, to a large part because none of them have been prospectively validated in a large cohort. Great.
Thank you so much.
George, Caitlin here. Thank you for a wonderful talk. It's really interesting to see you move the needle forward in a really fascinating way. Talk to me a little bit about how you're making that connection between simultaneous functional activity and determining the connectivity of those areas versus just simultaneous activity based on different aspects of activation. So, beautiful imaging, absolutely. And, I know you probably simplified it also out of respect for time, but I just want to hear, briefly how you're making that connection between those two modalities.
Yeah. So, one of the things that I think we have a big opportunity to do is to really steal from the neuroscience literature, because there has been tremendous amount of work in the last 5 to 10 years on brain network connectomics, such huge advances. And they're all directly applicable to neurosurgery if we can leverage those tools and exploit them to better perform surgery or to better select patients. And one of those is the idea that the brain is intrinsically connected in an organized way. And it really is just the most exquisite, elegant organization, because these brain regions that tend to coactivate, the motor cortex, the supplementary motor cortex, obviously they coactivate when you're doing a motor task. They're also intrinsically functionally connected when you're not doing anything. Another example is language mapping. And this is going to be prime time, I think, in the next few years for epilepsy surgery and for tumor surgery, where you have gamma mapping. When an individual is speaking, say, a child is too young to perform a task reliably, or too young to do cortical stimulation to test language, one can look at the intrinsic oscillations of the language network when they're doing the task spontaneously, and look at biomarkers like frequencies in the 30 to 50 hertz band, which is the gamma band. So obviously this is a talk for a longer symposium, but suffice to say that the more that we can leverage understanding from the neurosciences on the intrinsic connectivity of the brain, the more intelligently we'll be able to do neurosurgery in the future.
Swinging the conversation in a little different direction, because I do see a chat question, Dr. Rutka. This is from a pediatric neurosurgeon in Nigeria. At present, we don't have any forms of neurophysiology monitoring or EEG in the teaching hospital. Hence, none of this is available for intraoperative use. What will be your recommendations in doing epilepsy surgery here? And is it possible to get old systems for neuromonitoring and intraoperative EEG to help us be a step ahead? Dr. Raghav and Dr. Rutka, you both have done such amazing work globally. I think your perspectives here would be wonderful.
Yeah, I can start. Maybe John can weigh in too on experience in Haiti. But I go to Ukraine, which is not low income, but it's kind of low to middle income country. And over the years, I've been at centers where they have nothing too, as in Nigeria. So no EEG capabilities, no intraoperative navigation for sure, no ultrasound, zero. And you're left with a child who's got, let's say, a lesion and epilepsy. And so, I presented a slide in my discussion about temporal lobe epilepsy. And if you have a temporal lobe tumor and you have epilepsy, it's great if you had an EEG recording too, somewhere. Maybe in Nigeria, you can get for example, an EEG just to show that it does localize to where the tumor is. And if it's most likely to be a benign tumor in a child, then I think that that's amenable to epilepsy surgery in the form of removing tumor and potentially some juxta-adjacent brain, and essentially getting an excellent seizure outcome. So that for sure is in your armamentarium, as is like a lesion in some other location where it's quite clear that the semiology of the seizure fits where the tumor location is, and or it could be a remote injury that looks quite discrete to the brain, or some other kind of lesional epilepsy that you can treat in your country. And I've been to Ukraine. I've helped them with a lot of surgical cases where they almost have nothing as well. And you do the best you can, for sure. In terms of having equipment available, so over the years, like to send to Nigeria and so on, we've done that in Ukraine. And I think John has been doing that in Haiti. We provided equipment that helps to bolster the infrastructure that then allows neurosurgeons working in these countries to elevate their game in terms of epilepsy surgery. John?
That's a great question from the person who sent it. And of course, Dr. Rutka's answer is right on. I would encourage the person who asked the question to look at the International League Against Epilepsy's website, and they have structured the basic workup for epilepsy surgery management in the developing world. And as Dr. Rutka points out, that involves an EEG, which, obviously you need the machine and someone who can interpret it, a CT scan, and that's about it, as well as basic neurosurgical skill and the ability to be able to lateralize or understand language and memory. And you can affect reasonable results. And I think those basic guidelines are a good tool for anybody interested in managing epilepsy, which is such a profound problem globally. So we could go a long way by helping people understand that you don't need all of the fancy tools that Dr. Rutka and Dr. Ibrahim have at sick kids, or that we use here in Miami to do basic epilepsy surgery. I just think that a great deal more could be done. And since I'm asking my turn to ask a question now, I really want to know how Dr. Rutka and his team handle memory assessment in younger patients with intact memory when you're doing a dominant temporal lobe operation, and how Dr. Ibrahim decides his target in the thalamus when he's going to do DBS. And then I promise to be quiet.
Yeah, thanks, John, for that. I mean, that's the critical piece for any kind of temporal lobe procedure, is knowing the neuropsychology and determining what that entails. And so we have a really good team of neuropsychologists, and we rely heavily on them to kind of predict in advance what they would estimate the child's chances are for struggling with memory after a procedure that would take the mesial structures away. If we have any doubt, or if we're really concerned about it, what we might do is preserve mesial structures and come back another day if it looks like we didn't affect the result that we wanted in terms of seizure outcome on the dominant side. But we definitely have to rely on what they tell us, and their testing at various ages, including down in the age group you're talking about, young children, is not a perfect science. And maybe with what George talked about today and connectivities, maybe George will find an answer for us on how to predict that even in the younger child.
I'll address your second question about the target in the thalamus. Most people would say, so the only FDA approved target for epilepsy, which is in adults anyways, is the anterior nucleus, of course. So all these procedures are off-label if you work in the States in children. But I think there's a real danger to saying there's the greatest evidence for anterior nucleus, so we're going to do anterior nucleus in everybody. I think that's a real challenge. One, because one cannot transfer the knowledge from adults directly to children, and two, because I think that would do a disservice to those that probably would benefit from other targets. The way that we approach it, the way that I approach it, is actually very simple. In my view, the networks that are most robustly modulated by the anterior nucleus are limbic targets, temporal targets, frontal targets. So if a child has a seizure focus or electrographic activity within those brain regions, I think it's very reasonable to proceed with anterior nucleus stimulation. If a child has generalized epilepsy, certainly Lennox-Gastaut, which is the best evidence for centromedian in the literature, is for LGS. But if there's generalized, if there's LGS, or if there's extratemporal, extrafrontal foci with independent bilateral activity, I think the centromedian target is a much, much better target in those kids. I will say that that's my view, and certainly more data is needed. But in general, that's my approach to it.
It's nice to see that we have a really international audience listening today. We have people writing in from Chile and Colombia, in addition to Nigeria. I'll ask our next audience question, which was from a participant in Colombia, which was a question for Dr. Rutka. Actually, two questions. What is your favorite epilepsy surgery procedure, and what is the hardest epilepsy surgical technique for you? Both those questions were directed at Dr. Rutka.
Thanks, Heather, and thanks to Philippe who asked the question. And my favorite procedure is also the most difficult. That's hemispherectomy. Last week, Thursday, I did a child using the perinsular technique I talked about, who had slit ventricles. So, pretty much a full brain and the tiniest ventricles you can imagine. It's like a hemimegalencephaly case. And those are really hard, to be honest, using that technique. So, my understanding is that sometimes the more vertical approach might lend itself to those types of cases better, but maybe not. On the other hand, those types of procedure are really, for the surgeon, are technically challenging, but also very rewarding. And what I like about hemispherectomy is it takes you everywhere, right? And the type of surgery you're doing is pretty amazing when you think about it. The disconnection part of it that George mentioned, the anatomy, knowing, how to stay out of trouble, how to recognize consistent anatomical landmarks all the time, respecting peel borders and surfaces throughout. So, I mean, I find the steps in hemispherectomy are very, very interesting from a surgical standpoint. So that's why I say it's favorite. But also, it can be challenging, especially if the brain has a malformation in it that's challenging, or if it is associated with a situation like tiny ventricles, as discussed.
I think the next question from the audience might actually be a good follow-up for both you and all of our moderators as well, which was from an anonymous attendee. In your opinion, what has been the greatest advance in epilepsy surgery in the last 10 years?
Yeah, I'll weigh in very briefly and say minimalism. So making things smaller, whatever that entails. Endoscope, laser, smaller incisions, bottom of sulcus dysplasia, neural navigation directed resections, not subdural grids or even invasive monitoring. The less we can, less is more. That's a great adage, right? If you can do less and get the same result, why not? I think, when I showed you some of the images of the large subdural grids that we used to use, I mean, 20, 30 years from now, people are going to look back at that and say, that's barber surgery. You don't want to do that anymore. So there may still be a role for it in the future, but that's probably an era that's passing us by. And I would say minimalism is what I would say.
And then on that same token, Dr. Rucka, where do you see the field in about 10 years time from now? Where do you see the future of epilepsy surgery?
Probably more like advanced imaging. Like imaging's been great too. I didn't say imaging per se because it's not a surgical technique, but neural imaging's really allowed us to see things we never could see before. And it's going to get better. 7 Teslas coming in. We've got ways to, use MEG and PET scanning and, other types of, contrast-based imaging strategies that are going to allow us to see things that we just couldn't dream of, now. And 10 years from now, we'll probably see those things. So I would say that's going to be great as neural imaging. But then maybe George should weigh in on where this functional neural connections and connectomics is going to take us 10 years from now.
Yeah, I mean, I think that is the future, but I will even go a bit out on a limb here and say that I think the greatest advance in the last 10 years and probably the next 10 years as well is collaboration, because never before has there been such a huge international effort to collaborate across multiple institutions, be it in imaging, in genetics, in clinical outcomes, Clinepi. There is a very promising rising trend globally to collaborate across multiple centers, to pool outcomes together, to pool these biomarkers together to better understand epilepsy. Dr. Rutka and others can correct me, but I have not seen this in the past. And I think this is the most exciting thing, the willingness and the ability for people to collaborate to try to answer epilepsy-related questions.
Along the lines of utilizing our more minimally invasive tools, Dr. Rutka, Dr. Raga, what do you consider in terms of the best candidacy for LIT for hypothalamic hamartoma? Who wants
Go ahead, Jim.
Okay, so we've got quite an experience now. I think the worst candidates are the giant hypothalamic hamartomas, but they're bad for anything. You can't really predict responsiveness to the giant ones, and it takes multiple techniques and sessions for a laser, in other words. But yeah, small hypothalamic hamartoma, unilateral. You can do a disconnection. Fantastic. I mean, I think that those cases are really amazing in how well they do. But you're going to get some failures too, and we've seen that. And actually, George and I are exploring a case right now where we're going to try MR-guided focused ultrasound because we have a child with a hypothalamic hamartoma that has failed 3 prior lasers, and it's a giant one, and we can see the connectivity, but we just can't get at it with the laser. So we're going to try to do MR-guided focused ultrasound. That might be something to think about, as a future tool.
Yeah.
Yeah, I would agree that that I think LIT has was been embraced rapidly over open resection or endoscopic resection, but the failures and I think the hypothalamic dysfunction that is almost inevitable in those children, either endocrine or the hyperphagia, remains a challenge. And I think that focused ultrasound probably has a great potential. We've treated 4 hypothalamic hamartomas with focused ultrasound so far. I think there's been a clinical response in all 4 of those patients. I think it is the future, assuming that we understand where the important connections are. And I think, again, I'm hopeful that George and those that understand connectomics and can demonstrate the vital networks within a large hypothalamic hamartoma can then help guide and target our treatment. Because as it stands now, focused ultrasound ablation and LIT can only treat a very small focal region, and we don't really understand in the larger HHs what part of the lesion to treat.
Yeah.
And the more we do, the more harm we create. So,
Right.
I think I wish you guys success on that HH with focused ultrasound. I think it really has good potential.
All right. Well, I want to thank all of you for being involved this evening and taking time out of your busy schedules to be with us tonight. Those are excellent talks, excellent discussions. And, we thank you again for joining us tonight.
Yeah, thank you very much, Dr. Rucka.
Thanks, Hilda. Yeah, thanks, folks. Thanks.
Our next session will be on May 10th, so we hope to see all of you then.
Great. Thanks, Heather. Thanks, Shelley. See you.
Thank you, guys.
Thank you so much, Dr. Ibrahim, Dr. Rucka. Have a great evening.
Stay safe. Good luck.